We've had functional and structural imaging for quite some time. X-rays now have been around for over 100 years. And they're great for anatomy. And the recent development of functional MRI and contrast ultrasound, for instance, has started to give us a little bit of functionality. But I think everybody would agree, and including most radiologists, that nothing beats radiotracer imaging functionality. And more recently, the introduction of SPECT techniques and PET techniques has meant that we can localize that functional change much more accurately. And I think everybody will agree that the interpretation of the relevance of functional and structural imaging is easier when you have both together, either co-registered or side by side. Functional changes do precede structural change. And this is the real crux of it, that our confidence level of interpretation is much higher when we've got both functional and structural change. So how do we do it? Well, there are a variety of methods. We can view images side by side. We can acquire these structural and functional data sets at separate sittings and use Fusion software. Or we can do what we're really talking about today, is dual modality acquisition, i.e. acquisition at the same sitting. So let's look at a few of these examples. So we can eyeball the data set separately with computers, screens side by side, and we can correlate them ourselves to say a lesion at this site roughly correlates to that structural abnormality, for instance. Okay, and you can do that for a variety, for most functional data actually, and using a whole set of structural imaging techniques. And we do this every day, and for those of you who have been taken over by the CTPA era, this is a VQ scan. And we look at a VQ scan in combination with a chest X-ray all the time. Okay, this is something we do where we try and fuse our structural and functional data sets. And similarly for bone scans, okay, we like to see the structural abnormality. It's just that sort of harder bit of data set, and if the functional and structural abnormalities coincide, we're much more confident about what we're seeing. We can acquire these data sets separately, okay, on different days, and try to use Fusion software to co-register them. And we can do this with any cross-sectional study, with any functional study such as SPECT or PET. But you do need anatomical landmarks to do this, okay, either external or internal landmarks. And a variety of methods are available. You can use linear techniques where you apply the same rules to everything within the same data set and convert, say, a small square to a big square. Or you can use non-linear techniques where you can apply regional rules for regional change. And these things are useful when the patient position, for instance, is different between the two data sets, i.e. arms up or arms down position. And we can correct for that to some extent using non-linear fusion. And really, fusion techniques are best developed for brain imaging, and the reasons are obvious. Okay, it's a fixed organ, very little movement artifact, and we scan the brain all the time. So there's been a lot of experience and a lot of work done using fusion software for brain imaging. There are problems, however. It's time-consuming, it's very labor-intensive. And it's not always clear when to use fusion techniques, partly because you are limited by the time penalties involved. And then you've got to weigh up how beneficial is it compared to viewing things side by side. And manufacturers have really taken on the mantle of developing dual modality acquisition really as a challenge that we've set them, because we want to view the functional and structural data sets together, preferably co-registered to make our lives easier. And hence, we've come to this hybrid technology that we're talking about. And it's not just SPECT CT, obviously PET CT is around, and I'm sure all of you know that we've introduced our first PET MR in the UK, and that's now becoming available throughout. Just a little bit about history of SPECT CT. There's been enthusiasm about it for decades, but it wasn't until Lang and co-workers in the early 1990s integrated the two bits of hardware for SPECT CT and developed attenuation correction algorithms. And it wasn't that long ago, late 1990s, when GE introduced the first Hawkeye SPECT CT scanner, and we've had one in our institution since 2001. And I'll show you a couple of images from those early commercial scanners. And we're now at our current systems, and we'll be talking about that throughout the day. What about clinical applications? There are a lot of lists in the literature, and throughout the day, hopefully you'll learn about areas where SPECT CT is particularly useful. It's mostly used for anatomical visualization, but obviously we use it for attenuation correction as well. And these are the current systems available commercially now. And they range from sort of, I'd say, low-end CT to very high-end CT. And really, what's happened since the late 1990s is the CT technology. Okay, CT technology has improved so much, it's become so much quicker, the resolution's improved so much that that's really the main challenge that manufacturers have come to so far, but there is a way to go still, I think, to improve the SPECT acquisition, and we'll talk about that in a little while and throughout the day, hopefully. So a variety of systems available, and those of you who are purchasing systems at the moment, I'm sure, are aware there are now four providers in the UK for these systems. And this is what they look like. Okay, so some of them combine high-end CT with SPECT, some combine flat plate technology for CT acquisition, and maybe one of the newer boys on the block at the moment is this, where it's an add-on machine, so you buy the SPECT and then add on CT and an add-on PET, okay, similar to preclinical scanners that we've seen available for a while. So when to perform SPECT CT? Really, if you want to correlate the anatomy and the nuclear medicine data with certainty, you'd like the co-registration to happen. We also use it for attenuation correction, and as some of the speakers will tell you today, it can be useful for guiding surgery, such as for parathyroid scintigraphy, and can guide biopsy on occasion. There are issues with these machines. You do have to plan ahead before the patient arrives to decide that you might do a SPECT CT that day. And that's because a variety of QA is involved. And also, there is the additional time, so you've got to schedule your patients accordingly. The patient needs to be still. If the patient's moving around, there's little point in even attempting a SPECT CT acquisition, okay, because that co-registration just won't be there. What about problems? Well, there are problems. There is a time penalty for doing the scan. There is a temptation, because you have SPECT CT, to do it. The patient's there, you have a machine. Okay, but if a dedicated CT's been done 2 days ago, and it shows a lytic lesion in, I don't know, T5, and you've got increased activity at T5, there's little point in doing the co-registration just to prove that fact. There are misregistration issues due to movement, due to respiratory motion, and there are training issues, and we'll hear at the end of the day about some of the training that's available and how to get around the training for really 2 different modalities coming together. So let's look at a couple of images. This is one of the first images we acquired in early 2002, 2003. And you can see we've got good quality SPECT, reasonably quality SPECT, reasonable CT, but this was one of the issues with those early CT machines, that when you try and reconstruct in different planes, the slice thickness was so great that the reconstruction really was almost meaningless, actually. And then you had this thing, which is motion artifact from bowel movement, okay, because the CT took such a long time to acquire. And it was particularly problematic in small joints, small areas, okay, hands, wrists, and it was impossible to say, look, is this in scaphoid, is this in your foot almost, okay, because the co-registration was just so poor. Okay, I was quite excited when we got our first SPECT CT because we did a lot of bone scans for scaphoid injury because of the limitation with MR. But this didn't really confidently help because you weren't always sure whether that activity was within the scaphoid. things have changed, and I think you'll see some much nicer images. And this is the sort of thing we can do now. Okay? You can use surface rendering techniques to improve your CT quality significantly. Okay? It is diagnostic CT, it's as good as we get in standard CT. Okay? But that is really the main advance, I think, that's happened really in the CT technology. And again, a different example here where we're seeing tiny little lymph nodes and co-registering. Okay? So it is really CT technology that's improved significantly, that's allowed this transition to this new age in SPECT CT. So just to finish off, what about the future of SPECT CT? I think what needs to happen is an improvement in detector technology, where we have detectors with sufficient temporal and energy resolution to discriminate between the primary radionuclide photon, the X-ray signal, and also account for the scatter from the photon. Only then I think we're going to get true registration, and really where I think imaging is going, and I think this divide between nuclear medicine and radiology is already happening, but my prediction is within 5 to 10 years I think that'll go with this hybrid imaging, because we do need functional data, we do need structural data, and I think if we can optimize both, I think that's the way that imaging will and can go.